Hello everybody and welcome to this lecture, to this topic. We will talk today about the worn dentition in extensive rehabilitation cases, and mainly we talk about erosion, chemical erosion, and we try to see how it's possible to follow a kind of predictable clinical approach. So first of all, I would like to say which kind of role the clinician has in these cases, difficult cases or extensive rehabilitation cases. When I talk about tooth wear, we can have different etiology. And first of all, you can say also how much wear you have in the patient mouth. You can have some moderate situation like this. This guy is on the 30s, 31, 32 years old. You have already many different kind of etiology in this particular case, attrition, erosion, abrasion. But the other side, the middle picture, you could see a young lady, 23 years old, that was cut away already, half of the teeth length. And that is absolutely severe situation. Not to say, what about this guy, that is still maintaining the roots of the upper teeth anteriorly, but they are completely covered by the lowers. You cannot see, we just see the roots, that's all. No any kind of abutment to remain in place. So that's the extreme cases of wear that is really very complicated to be fixed in some way. So let me go back to the etiology and explain to you that we have a different kind of etiology. For example, we have attrition. That is classically when you have the tooth-to-tooth friction. And you can see people that have the facet that are coincident each other in the upper and lower arch. That is very classic of the possibility of the patient to move around and to grind the teeth completely. We have then abrasion. Abrasion is a characteristic when you have a pen, a pencil, a pipe, something that you are chewing on between the two arches. It's like something that you shouldn't do it, but you do it anyway, actually. And it is absolutely some external device, external tool that is the cause of this problem. Then you have the erosion. And I believe the chemical erosion is the most important etiology today, because it's increasing more and more. So we have a bulimic patient, still possible to see young ladies with this problem actually. And then we have many people that without knowing, they suffer from a gastroesophageal reflux disease, so-called GERD. And is this point also possible to see that the food and the beverage are really in charge in this kind of situation. And that will be seen in a while. And then I have the abfraction, that is still a kind of controversial issue. Seems to be a kind of occlusal overload, but it's still not really defined 100%. On the clinical aspect, you could see this case here, for example. You have seen on the lingual molars that you have a big erosion. And that is quite classic of this kind of a characteristical situation on eroded patient. You can see some classic kind of attrition. Very clearly is presented attrition over here with the antagonist. It is quite easy to see how are the facets in this area. So when you talk about the abfraction, I could say that is actually possible to have this V-shaped lesion, and they present a kind of a triangular lesion along the cervical margin of the back surface of the teeth. Why it happens? It is believed that the enamel there is thinner, and that is the reason why in the presence of occluding forces or overloading is quite prone to fracture. That is the point. With the occlusion as you see on the blue arrows there. So quite recently there was a consensus conference or statement on managing guidelines on severe tooth wear. And first of all, the definition of severe tooth wear is the tooth wear with substantial loss of tooth structure, with dentin exposure, and significant loss, more than 1/3, so it's a really big one on the clinical crown. And that is really the definition, how to define today the severe wear. So wear can have a different grade. The grade 1 is superficial lesion that involve only enamel. That's all. Grade 2 is a lesion that affects less than 1/3 of the tooth, but including both dentin and enamel. And the grade 3 is a generalized lesion affecting more than 1/3. It is, of course, including in this case also a dentin and enamel. So we should divide also the physiological than pathological wear. So physiological wear is very often when examining the patient who show tooth wear, we should separate the two parts and divide it in physiological and pathological one. So you have some grade of wear anyway, even though you don't do any kind of grinding procedure, for example, or any other etiology in place. So the tooth wear, attrition, erosion, abrasion, all these forms are considered today to be really increasing a lot, more and more, as also this article is showing. And many studies suggested that the tooth wear caused by the erosion is very common. It can go up to 56%, from 5 to 56%. Is so present, much more than you can believe. And most studies agree that the levels are increasing in the young individuals due to the new kind of beverage and new kind of food that are today very fashionable to use on the young population. It is very complicated. So you can see some wear on posteriors, wear on anteriors. You can have a wear everywhere. So you can really check it each time with a different etiology, different position. And that is, for example, erosion. This volcano-shaped lesion, cupping, cratering. That's a very classic of erosion, dental erosion. And that is also dental erosion. So we can divide this kind of erosion by endogenous and exogenous reason. You have endogenous one when you have a bulimic patient, reflux disease, and exogenous when you have a different diet than in the past, maybe, with a lot of acid foods. So let me start with exogenous wear. Dental erosion, unfortunately, is an irreversible loss of dental hard tissue that is related to the chemical process without any involvement of normal decays like caries, because you have no microorganism here. Such destruction is gradual, localized, and unfortunately irreversible. That's the most problematic part. Remember that a minor loss decreases with the rise in pH. It will be a critical value of the pH, that is, according to the different authors, between 5.5 to 5.8 in pH. In the United States of America, 300% increase in soft drinks consumption in a period of 20 years has been reported. So it means that there was an incredible amount of new beverage. 300% different of soft drink came out on the market. And actually, erosion is, again, as I said, anticipated to you already, has been reported that any food that has a critical pH value less than 5.5 in pH can become a corrodent and demineralized teeth. That is the problem. And that is really something that you can understand it. So let me give you an example. When you talk about the neutral pH, neutral is a 7.0 normally. So how much is the acidity of gastric acid? That is the most acid part of our body, at the same time also more than every food. You can eat it. So gastric acid is 1.0. It's also curious to know, for example, other normal fruits like lemon, for example. Lemon is quite close to gastric acid. It's 1.7. Coca-Cola is 2.3. So all the other steps like that, even the enologist, the pH of the wine is between 3.4 to 3.1. And also the pH of pure water is 2.7. Red Bull 3.4. So it's interesting to know all this data. And it actually are important to understand how many food can be not healthy today. Even though, people that like to have this kind of diet, of course, emphasize the other characteristic and the features of this. But in terms of enamel erosion, this so-called healthy food is not healthy for the teeth either, because lacto-vegetarian diets include a large amount of fruits, of juices, of vegetables, and normally the salad are dressed with vinegar and lemon many times. So it's interesting to say that with the control group, subjects did not show dental erosion. Erosive lesions had a prevalence of 77% of lacto-vegetarian. So it's important to understand that, mainly on that. And acid in the oral cavity through the carbonated soft drinks and fruit juice, and keeping the liquid in the mouth for some time before swallowing. And that will cause surface pH to decrease significantly. So swishing soft drinks in the mouth before swallowing them will also increase the erosion. So they are strong buffer, this kind of soft drinks. And their pH remain low for a long time, and especially is recommended by other authors not to brush the teeth in the meantime, because they create some loss of enamel. So this process competes with the buffering capacity of the saliva and is able to alter it. Why? Saliva is very important part of our defense. We can fight it through the saliva, because the saliva removes the food particles, sugars from oral cavity, has a buffer capacity, neutralize the acid from intake. It reduces the potential of erosive agents, is creating a kind of pellicle with prevented mineralization of enamel surface, and containing inside the calcium and phosphate maintain a state of supersaturation near to surfaces. So provides also the calcium and phosphate, fluorides, etc., etc., etc. So a very important role. And that's the reason why we should create some tests. You should do or perform some tests in order to understand how much saliva we produce in a certain time, and this kind of buffer capacity of the saliva. Can be high, can be medium, can be low. This is one of the tests that you can do it. That's this company now. I think they don't produce anymore this kind of test. Maybe not many people buy this kind of test, but for me very important. Now we have another from GC that is very similar. So endogenous wear by bulimic patient and GERD. So endogenous erosion with a reflux situation. Although there is no fixed critical value, even though it's 5.2, 5.8, since the gastric juice is very acid, is 1.0 as I said. If you vomit and have regurgitation, you can produce important lesions in the teeth. So at the beginning, the acid removed the palatal surface of the maxillary anterior teeth. Later, it happened that also the palatal cusp of the premolars and the molars will be more and more affected. Let me show you this case. This is a kind of situation that is quite classic. You can see seem to be have done kind of preparation, the chamfer preparation, the lingual part, but it's not. It's just the natural preparation, preparation by the acid. So seems to be chamfer. But why we can find this kind of situation here on the palatal surface of the upper anteriors and not on the lower anteriors? If you think in a moment about this, what I said now, you can find that it's true. Normally you have this kind of problem on the palatal surface of the upper teeth, but never, or almost never, on the lower anteriors. Why? Because in the lower anteriors you have the sublingual glands that goes out from there. So saliva is producing there and protecting the lingual part of the lower anteriors. On the opposite, when you see this case, they have not any glands, saliva glands, close to this palatal part of the upper anteriors. Secondly, when you say some word like S sound, or like D, like dod, or dog, talk, letter D, consonant D and T, as putting the tongue against the palatal part of the upper teeth. So you are touching there. And the palatal part of the palatal part of the upper teeth are in this way invaded by the regurgitation that was keeping in between the papilla of the dorsal part of the tongue. So when you talk with the tongue, you can touch all the time this palatal area, and your tongue is capable to catch some reservoir of acidity that goes every time when you talk against this palatal part of the upper teeth. In this way, you are creating this kind of erosion, chemical erosion. And that is very important to understand. So the tongue is likely to play a role in this process. The dorsal surface, as I said, is full of papilla. So this topography for retaining the regurgitated acid is perfect, and for keeping it against the palatal part of the upper incisor. So another specific feature of this erosive process is the surface remain intact and appear in high relief. At the same time, the restoration doesn't change the volume, and the tooth change the volume. So this restoration standing out from the eroded dental surfaces. The presence of stain or pigmentation, tobacco, coffee, tea on eroded surface suggests the old lesion or the erosion is currently inactive. Yes, just going back one, showing again this area. Because when you talk to the patient and you want to know if they lie or not, because many times the young ladies try to hide this problem, especially if you have your parents with them. But you can understand, you can translate what they say. You ask them, are you sure that you stopped to have this kind of bad attitude, to have this kind of regurgitation, bulimic attitude? And they maybe say yes. And you can say if you can see if they lie or not. Because if we have some stain over this dentin area, at this point it means that the people, the patient will stop it because they have a stain, they are not going away. If you're going away, it means that you have clean all the time this area, clean with the vomiting, with the regurgitus. So you have no stain there. So you have no stain, shiny appearance means that it's still there. The problem is still there. If you have a stain there from tobacco, from coffee, tea, it means that they stop it. That's a very important diagnosis that you can do at the beginning. So, what to say? The acid affects the maxillary incisal edges, which have a thin and chipping edge. It's almost transparent, as you know. There is not the case of mandibular incisor, as I said, are better protected by the action of saliva. So they are hardly ever affected. So they are not normally affected. So endogenous wear by GERD is incredible because many people are asymptomatic on that. They don't know they have reflux, but they have it. So the GERD has been reported with varying prevalences in the population, maybe as high as 42%. So very, very high level. It means 1 every 2 people. Let me give to you an idea about one case that was treated. It was one arch treatment, in this case prosthetic treatment. The young lady, 21 years old, was a bulimic patient, and the first step I would like to add in this particular case is to increase the video. Why? I don't care if they keep the video that was at the beginning or if they have lost the video. What I need is to find space. I cannot kill a lot of teeth doing endodontic and maybe post and core because you have not enough space. So you have already some lesion on the lingual part. As you could see, there is dentin over here, like that. It's just dentin. Okay, so if I don't increase the video, I needed to cut back these teeth, and then for sure I will arrive on the pulp area, and I needed to devitalize the teeth. That's for sure. It is something I would like to avoid it. So what I said to myself, why shouldn't I increase the video to create some space for the lady? But we have to consider different steps. So to really consider the entire and overall picture of the case that you have in front of you, and to understand how could be possible to rehabilitate this case in the proper way. So we know that every prosthetic treatment starts with the position of the incisal edge. And as you could see here, we have very short teeth. So the incisal edge most probably is not in the right position. Let me check with you, because the length is 5.5 millimeter. So it's wider than longer. So we have 8 millimeter wide, and 5 millimeter 0.5 is the length of the teeth. So you should increase 4 to 5 millimeters to achieve the nice final outcome. So let me check, is still the overbite is about 1.5 millimeter right now. And let me start with the initial part of my evaluation. That is always, as a starting point, the position of the incisal edge that is characterized by the dominance of central incisor, that is the more convex place of the convexity of the incisal edge. So I'm talking about the tooth exposure at rest. The two central incisors were not almost visible at the beginning, or it was just 0.5. I did a kind of easy mock-up, not from the lab, but just myself with my fingers, very rough and fast way, just to have an idea how much I could increase the length of the central incisor. And I realized that it was 2.5 millimeter was the one that I would like to have it. Of course, that's it decided, not just with the picture, but seeing the patient moving, and having the chance to do a movie or to look at the patient, to have the look of the patient in front of you. That's the only way to really understand and judge what you have to do and decide what you have to do. So 2.5 millimeter of increasing. So now we go from 0.5 millimeter rest position to 3 millimeter. We cannot add more, even though we have a 5 millimeter 0.5 plus 2.5 become like 8. So it's not enough. We should increase the length even more. But the rest of the increase will be not on the incisal edge. So automatically, of course, you know, the next step will be on the cervical area. If you decide not to do any ortho, in this case, you could have done just the increase of the incisal edge if you have intruded the teeth before. But that's not happened in this case. We just did some crown-lengthening procedure on the back side, as you will see next. So in the meantime, we know that we have a 3 millimeter of increase, 2 millimeter 0.5 of increase of the length of the incisor, is altogether we have the rest position that is 3 millimeters. Then, as you said, we have to have some reference. We know that the central incisor of this patient are 8 millimeter large and 5.5 long. And we know that the ideal proportion between width and length will be that the width should be 80% of the length. So if the length is 11, the width should be 9 millimeter. So that is what will be ideal, because the ideal length should be 11 millimeter, 10.5, 11. Ideal width between 8.5 to 9 millimeter. Ideal proportion, as I said, 80%. The width should be the 80% of the length. We can vary from 75 to 85. 80 is the maximum effect, the better solution. So we theoretically should elongate completely there or going just cervically. But of course it's not convenient. Why? Because if you increase just the length of incisally, you can have the rest position with increase of visibility up to 5-6 millimeter. That is exaggerated. At the same time, you also increase the overbite value. That was 1.5 plus 5, it will be 6.5. That is crazy. So you have to calculate all this stuff before deciding where to position the incisal edge. But the first step is the position of the incisal edge, is the position and the visibility of the two central incisors on the upper arch. So we need to do aesthetic, functional, and phonetic evaluation. We have also, with the Get Up, made this kind of evaluation. We have to lengthen the incisal edge 2.5 and 3 millimeter the cervical edge. So what we decide to do it is more or less what you see now here. So let me better explain. One, you have to take into consideration this very important step, the most important step maybe, that is the define the incisal position. You should start with some functional, aesthetic, and phonetic evaluation. Starting with aesthetic evaluation. First of all, we should see how much is the tooth exposed at rest, as we already discussed. How much should be if you add some direct mock-up as we did. We came from 0.5 to 3 millimeter, and that is okay. Then, what about the incisal edge curvature? Is cut away, is completely flat, or is it even reverse? You should become convex, following the lower lip line of the following the concavity of the lower lip line. And then, what about the incisal edge curvature? We said, what about the incisal profile? Looking the patient from the profile and see if you are inside the vermion border of the lower lip line. Remember, the vermion border is the border between the wet part of the lip, the lower lip, that is internally positioned, and the dry part of the lip that is externally from vermilion. And that is exactly what we need to know. What you need to know. Then, the smile line of the patient. What about the smile line? Is has smile line, low smile line? Depending on that, you know, it will be important to have a perfect length incisally and cervically, or having perfect alignment of the gingiva. If you have a low smile line, maybe that is not so important. What is important is incisal edge at all. Only that. And then you have to be inside this value that we described already, to proportional length. So the width should be 80% of the length. And the normal length is about 10.5, 11 millimeter for a natural, healthy central incisor, like should be in this young lady that is just 21 years old. So let me go then to the functional evaluation after having checked all the aesthetic parameters. And on the functional evaluation, we can say we have to calculate the overjet overbite value. What we know is the following. We had 1.5 millimeter of overbite. We have added again 2.5. We become to 4. Then we have increased the VDO of a couple of millimeters, so from 4 to become 2. So the final kind of overbite will be around 2 millimeters. Plus overjet was minimum, was not so much. We want to increase it. So because we have increased 2 millimeters the vertical dimension anteriorly, we can have a gain about 1 millimeter of extra overjet. So it will be flatter guidance. It will be great. Of course, without touching, without having any posterior interferences during excursive movements, anyway, we'll have a good cuspid guidance, anterior guidance, generally speaking, moving the mandible in an easier way because you have increased the value of overjet. We have decreased the value of overbite. Now, last but not least, we have the chance also to see the phonetic evaluation. We have discussed already about the F sound. Again, we should stay within the vermiform border of the lower lip line to be in the wet part of the lower lip. And at the same time, with the S sound, to see if we have an anterior position of the S sound of the mandible, or will the mandible stay under the position when you say 61, 62, 66. There are some people that say 61, 62, 63. Some other people say 61, 62, 63. So in this way, you have to consider that it's very important to understand that before starting to do the case. So all these three evaluations that are to be done in a proper way before deciding what to do. So our decision was to establish the upper arch only, putting the patient, of course, in CR, because as we said also in another lecture, once you start to do one arch at least, you lose completely the dental position of the teeth. Remember, we cannot keep the habitual or the acquired or so-called acquired or so-called also maximum anticipation position that you had at the beginning. Why? Because as soon as you cut the teeth, being a dental position, and not related to the TMJ, you lose completely any reference occlusally. So the mandible goes around, and you have to find a place for them. And that's the reason why we said that I want to put this patient that to do the full mouth rehabilitation or even one arch absolutely in CR position. The reason why, as I said already in the previous lecture, is because I would like to have a repeatable position. Not just because I believe it's the most physiological one, but also because it's repeatable. And repeatability is one of the most important characteristics for us, and especially for our dental technicians that are to do the cross-mounting procedure in order to copy what we have obtained already on the mock-up or on the provisional, and you want to copy on that because it's testing. I have tested already in the mock-up and the provisional going well, so you want to copy, and that is needed to do the cross-mounting procedure. And that is possible only, again, if you have the same bite record in every kind of phase of your work. If you have a different position of the bite record, it will be crazy. So that's an important. If you put the CR, the patient in CR, that will be very possible to repeat the same position. And again, it's very much more important the repeatability of the position than the precision of the position itself. So now, in this case, we have increased the LDO 2 millimeters on the upper arch only. And we had the chance to put the patient in CR as we discussed. We have elongated the incisor 2.5 millimeters incisally, and 3 millimeters apically in the cervical area. And we put also and move the teeth backally. In this way, we had the chance to enlarge the arch, having the chance to increase also the width of the central incisors that were just 8 millimeters. We have the chance to elongate the teeth up to 11. So we want to have like 8.89 millimeters of width. So we increase the width, we increase the arch. Doing that, you also decrease the need of tooth preparation because we had already the thickness of your restoration between the original teeth and the final position of the teeth. If you come out 0.5 or 1 millimeter, is like to have having done already a preparation of the same thickness. Maybe you have to prepare almost nothing, but you have already 1 millimeter because you put your teeth 1 millimeter more ahead. So you have already the space for your ceramic. You don't need to prepare as normal for 1 millimeter because you have already positioned the teeth more out. And that is what you've done in this way. Move the teeth backwards to increase the teeth width. So that is our treatment plan of this patient. It is important to understand that then 2.5 incisally, 3 cervically is not done yet. I want to show you now what you've done. So that was the gummy smile of the patient, very bad gummy smile. We have increased cervical, as I said, and that's the preview what we want to do. So we want to increase 3 millimeters approximately all the cervical area, plus adding the 2.5 incisally. We did some internal mock-up. Stefano Gordi did the surgical procedure. We have as reference 11 millimeter length as ideal one. That is after surgery. We wait for the soft tissue healing and maturation. Having increased 2 millimeters of vertical dimension, we obtain to keep enamel, not just backally, where you could see there is a lot of enamel, even though you have some island of dentin, but also crucially, where you have enamel. So we have the chance to keep enamel in 70% of the total amount of the tooth structure. So enamel maintenance, that's a case of more than 10 years ago. You see the preparation is not so minimal like you do today, as you have seen in my lecture, but still you have a lot of enamel, and not classic preparation, are still quite conservative. It will be more around more than 50-60% of enamel for sure. We finalized the case. We had to cover also the marked discoloration of one central incisor, as you could see here. But we prepared it to be more in this case, of course. And we had the chance finally to cover anyway this discoloration, to finalize the case on the upper arch completely. Having the chance to cover the palatal part of the upper anteriors, in order to avoid any kind of grinding procedure. Having increased 2 millimeters anteriorly, I have right now at this level here, 2 millimeters of space, a 2 millimeters of ceramic. So very strong material right now. It's monolithic material over here. Okay? At the same time, I could say we have a covering without touching anything here. If I touch here a lady 21-year-old, I will go to the pulp. I could have kill the pulp of this lady. I wouldn't do it. So I didn't. I just added. It was a kind of an addition procedure over here. The space that was open in 2 millimeters of increase of BDO was already gained for the material, 2 millimeter thickness. I want to show you the only difference between before and after in terms of removing teeth is just this. You need to remove it to put an implant. But at the same time, look this. How many decays you have here? Big decays. Look, huge. But also, thanks to the increase of BDO, there was no one devitalized. All vital teeth. And also, of course, one implant here that was not possible to keep it. That's at the time of delivery. Of course, it's important also to see what happened next. That's the new smile line of the patient, with a big improvement, of course, after surgery and at the end of the finalization. Again, the rest position at the beginning and the rest position at the end of the work. 0.5 at the beginning, 3 millimeter at the end, after having tested and proved that that was the exact value that we should obtain with the mock-up. We have tested with the mock-up and we have confirmed with this kind of ceramic work. Now it's the case 10 years later, and I can say that I'm pretty satisfied about the final result because it's still everything in place without any problem at all. Very good aesthetic integration, good functional integration, and good also biological integration, I believe. So I believe that we have a nice work done, and 10 years later, again, that's the final result with the close-up. And I believe that in certain case, the kind of combination between aesthetic parameters, functional aspects, and also phonetic aspect can help you to find the final kind of rehabilitation that is ideal for you. I believe that this is the most important step, going step by step in each kind of part, adding all these parameters and checking it with your dental technician or with also other of your team, other dentists of your team, allow you to achieve the best result you can. I hope you enjoyed this lecture. Thank you. We'll see you next. Bye.